you all for joining us, and thank you, Dr. Brandenberg, for sharing your expertise and your templates with us. Just to give a little background information about Dr. Brandenberg, he is the current Chief Medical Officer at Bristow Medical Center. He has been in that position for 10 years. He received his medical degree from OU, and he did postgraduate training in emergency medicine and internal medicine. He also received his epidemiology Master of Science degree from the University of London. Some of his experience in disaster response and preparedness include he served as a trauma team leader during the response to the bombing of the Oklahoma City Alfred P. Murrah Federal Building, and also as medical director of Camp Gruber during Oklahoma's response to the Hurricane Katrina disaster in New Orleans. He reached out to us over the weekend with his templates and his great expertise, and so we wanted to share this information with our rural facility. So, with that said, I believe most folks will be muted during the call, but if you have any questions at all, feel free to submit it through the chat box or unmute your lines and just blurt them out. I will be watching the chat box, though, to see if there's any questions come in. So with that said, Dr. Brandenberg, I will turn it over to you.
Thank you, Laura. And I will state for the record that the templates were a team effort that involved our physicians, nurse practitioners, and PAs at Bristow Medical Center. It was something that we worked on together. Each of the providers had their own assignments and provided the drafts of templates, which we then edited. And we've been editing them as we go. So it's a team effort. And I'm appreciative and proud of our group for putting this together. But most importantly, I wanted to make sure that these templates were something that we could at least discuss and offer to the rural hospitals, in particular throughout Oklahoma. And if they're used by other groups outside of Oklahoma, all the better. But for starters, I think what we'll do is just go over an update, and then we'll work through some of these templates. And I want to also offer as much time as possible after we speak, after this talk, that we have time for questions and answers, and I'll be happy to stay on as long as it takes to get questions answered. But for starters, let's go over the update. This is a pandemic that we've been keeping an eye on now for at least a good couple of months. Many of the epidemiology folks around the world, but even before then, I think in December, the CDC was alerted to what was going on. But once we understood the basic characteristics of this pandemic and the fact that it looks and has many of the characteristics very similar to Spanish influenza 100 years ago, we knew we had ourselves a worldwide problem. And in fact, the modelers from the very beginning have been pretty spot on accurate with what's coming and what has already transpired. But what I want to do is go over this paper that, in brief, that just came out last week from Imperial College London, and a real fantastic group of epidemiologists that collaborates with World Health Organization. And this paper gives some indications of what we are to be expecting in the next several months, particularly UK and the US. And they compared and contrasted the two countries. And there are some slight differences, but for the most part, what we're going to be experiencing will be very similar between the two countries. And you hear people talk about smoothing the curve. And what they mean is that by putting into place public health countermeasures, we can impact quite a bit the overall numbers of people that are sick, as well as critically ill, and the deaths. And this graph really does a good job of explaining that. And this is the UK graph. They didn't put one in here of this sort speaking to the US, but on this particular graph, what we're seeing is the population epi curve that will give some indication of when we can expect the peak of illnesses, the peak usage of critical care beds, and the death actually will follow by 3 to 4 weeks from this peak right here, but the peak right here at the very top is what we would expect in the UK, and it would be similar to the United States if no countermeasures were put into place, and the countermeasures being social distancing and isolating those who are sick. And you can see over here the description of those different countermeasures and what the collective effect will be on this curve if they are put into place. And I think it's relatively safe to say Oklahoma right now has put into place quite a bit of these countermeasures. And so we can expect our peak to be pushed further down into the calendar by at least 3 or 4 weeks. And we will diminish the number of ICU beds that will be utilized by doing these things. If no countermeasures were to be put into place, the estimates by these researchers would be that the United States would have over 1 million deaths. If we can put these countermeasures into place and fairly robustly, then we can decrease this overall mortality and morbidity by potentially down to about a third of what we would expect. And that would still eclipse the surge capacity that we have in our hospitals. So we would still be well over the number of ICU beds. And I think in Oklahoma, we can expect, just like most states, that the numbers of critically ill patients will vastly over and will exceed the numbers of critical care beds that we have in Oklahoma. So I think hospitals right now are preparing for that surge. And that's the importance of these social distancing measures, which you're hearing about, decreasing mass gatherings, closing schools and churches. So that's a bit of a segue into what I want to talk about today, which is what we've been doing in Bristow and what I think might be something that other small towns and medium-sized towns as well in Oklahoma might be interested in taking a look at and maybe scaling up some of the things that we've done. So with that in mind, I will first talk a little bit about what we did with regard to our hospital system, which is we went ahead and put into place our emergency operations plan that set up our hospital incident command system and went ahead and established some chains of command as far as the response to the pandemic and the patient surge that we're expecting. And keeping in mind, if you look at this graph, we're really just at the very beginning of this curve. The peak will be probably with countermeasures in place, the peak of the diagnostic positives and the hospitalizations looks to probably be somewhere in late June right now. So we're barely seeing, although we are seeing patients, we're barely seeing the upswing yet of the numbers of patients. And over the next few weeks to a month is when we're going to really see a steep increase in the numbers of patients presenting to our clinics and emergency departments. With regard to the principles of disaster medicine and how those apply to pandemics, I think it's important to talk about the fact that a pandemic disaster is really a humanitarian disaster that requires an all hands on deck approach, not just a medical approach. And so we set up a task force in Bristow that involved all aspects of the community that we could think of that would be somehow potentially involved and would be impactful in the response in a helpful way. And so that included the mayor's office, the police department, business leaders, veterinarians, anybody that was involved in the social needs of the community with regard to housing and food. And then, of course, our schools and churches were also included. And leaders from those sectors of the community are members of the task force. That is something that we were able to get going early in March, but it is not too late to do that. In fact, I would encourage the hospitals to reach out to your city leaders and see if you're not able to put together a task force. Meetings will be probably not very easily held right now because of the mass gathering aspect of that, but they can certainly be done by telephone and conference call, as well as Zoom meetings like this. The important thing is to keep in mind that there's going to be a lot of potential problems that will arise with families and patients when they're isolated and quarantined, and as well when jobs are lost and businesses are closed or at least modified. And that does involve the community, because the needs of these folks are going to be wide and broad and quite different from the medical needs that are met by hospitals. And if there's a team approach to this, then I think it's going to be beneficial. And it's something that we've known this from past disasters, Hurricane Katrina, as well as Oklahoma City, but any humanitarian disaster around the world is generally requires a multifaceted and multidimensional approach that the community can come together and provide. And so I think the medical aspect of the disaster response is really just one piece of it. We'll talk more about that. And for the most part, that's what we'll focus on here. But I think it's important to at least introduce the concept that this is going to require a community approach that will work integrally with each other as well as with the hospital system. It's important to keep in mind that disasters require a very flexible approach, and that protocols are difficult to implement because each disaster is different and unique, and each town is also unique and will have different assets that they can bring to the table when they respond to the challenges. So flexibility is a key point. And then I think for this particular pandemic, what we know is that the elderly and the patients with multiple medical conditions seem to have the highest morbidity and mortality, and that's going to require very special attention to the elderly of the community, as well as those who have multiple medical problems. And that involves quarantine and isolation to more stringent degrees than otherwise, and that does also involve the protection of these from those who might be carriers of the virus, even when they're family and friends, and that presents challenges in and of itself. One of the other things that's important in disasters to keep in mind is that all disasters are mental health disasters, and we need to be looking out for the mental health needs of the community. Every one of us, whether we're in healthcare or a patient, are going to be impacted and from a mental health standpoint. And that's not just to mean people who had pre-existing mental health problems, but everyone. And there's also well-known, it's well known that volunteers will be very helpful in disasters if they're put to work in the correct and safe way. And that's because volunteers and those who are not directly involved in the response have a need to help, and that the inability to allow that avenue for help can also create its own mental health problem, such as depression and anxiety. So one of the things we've done in Bristow is we have stood up a volunteer force of the high school and college kids who are out of school, and giving them the ability to run errands and bring valuable and items such as food and medicines to the patients who are isolated and under quarantine. So with that basic introduction to the town and the community approach, what I'd like to do is go over these templates, which I will start by saying are not, these are not protocols by any measure. And I've made sure they're all in Word or Excel documents so that anybody may be able to utilize them, but particularly edit and take out what you want, put in what you need based on your own impressions of what's required. And then, of course, as this surge of patients approaches in the next several weeks, the situations are going to change, and these templates will potentially require some editing to meet the needs of your individual and unique hospitals. These templates were put in on paper form and pre-printed in our two hospitals because we anticipate that with a large surge of patients, we're going to be unable to accommodate large numbers at peak times on our electronic medical record system, just because the efficiency is just not there. And so these paper templates will allow rapid patient throughput in the emergency departments and clinics. So the first thing that I'll show and I'll pull up is what we have posted in our at our front doors of the hospitals. And because this particular viral infection, the coronavirus, is mild in most patients, and in those patients, they will do well without medical treatment other than rest, fever control medications, and fluids. We are making it our goal to keep those patients who have mild illness at home. And that includes stopping them at the door of the hospital, taking a phone call, asking them to call us in the ER, taking a phone call triage, a report, taking down their name and number so that we can get back in touch with them if needed, making sure they have our number, and giving them advice so that they will be able to isolate at home and recover. And if they do suffer any increase in severity of symptoms, they know that they can come back to the facility or call us first, and we will give them guidance. So the first thing that we've put into place is are the stop signs. And what we did use are actual stop signs. I don't have a photo, but we have an actual stop sign in front of the front door of each hospital, as well as the emergency entrance with these instructions. And if they don't have any of these symptoms or exposures, then they can proceed as they would normally have into the entrance of the hospital. But if they have these symptoms or exposures there, then to get back in their car and call us, and from there we'll give them guidance. And so that's a template right there that could be used and would be modified, of course, for your particular facility and phone number. The next template here is a decision screening tool that will change over time, because the reason it'll change over time is as the prevalence of coronavirus here in Oklahoma increases. Down at the bottom, you'll see step 3, those geographic areas that have been affected and the exposures will be different. But for starters, we're asking, and this can be done over the phone or it can be done in person, but we're asking the patients whether they've had any of the symptoms of coronavirus infection. And I think it's important to keep in mind that anytime a patient that has symptoms enters your facility, they are then potentially going to expose your hospital staff and your patients to the virus. And therefore, again, I will strongly reiterate that if they have mild symptoms, you do not want them entering into your hospital if possible. And if they have moderate symptoms, I think it's something for you to probably put them through a further questionnaire to find out how moderate the symptoms are and whether or not they can also be managed at home. So once you determine that you have a patient with symptoms, it's important to put a mask on them, a surgical mask, not an N95, but a surgical mask. And then you can put them through the further parts to the questionnaire. If they have exposure, then they potentially are going to be a high enough risk that they'll meet the threshold for testing. And if they do not have the exposure, depending on test availability, the decision will be made then whether or not to test. But I would say that, and I think it's important that at this point in time, because we have such a shortage of testing capability in Oklahoma, that, and we're being told that if the patients have mild symptoms, they're unlikely to be tested, or the testing, even if you submit a sample, will unlikely to be run. that I would simply assume at this point and from this point going forward that anybody with upper respiratory symptoms or lower respiratory symptoms be considered positive for coronavirus, because we know it's spreading throughout Oklahoma right now, and we don't know to what extent because of testing, lack of testing. And so if you have a mild symptomatic patient who you are not going to test, I think it's imperative that this patient be considered to be coronavirus positive and be isolated at home for 14 days. So the paradigm has changed. The reality of how we practice right now has changed dramatically, and work release for 14 days if they have a job is important, and for your community to try to decrease and push the curve forward and decrease the number of cases that are going to occur in your community. So this is the decision tree that we've been using with phone calls as well. Now, it's important also, if the patient does make it into your ER or clinic and you're going to put them through this questionnaire and as well any forms that need to be filled out, it's important, I think, at this point that the patient does not fill them out. The patient does not write with a pen or touch the paper chart, but that all of those things are done by your staff at the hospital. This decreases the potential that the paper and the pen become a vehicle for viral transmission across from patient to staff. Okay, so we have put together pediatric and adult telephone triage forms, and this phone number has been fairly well established and communicated throughout the community. We have now a dedicated phone that sits in the emergency department that is for these calls only at this point. And so if you have that capability, I would put that into place, and that way you have a phone that sits there 24/7 to be answered for community questions about the potential for infectious patients. And so we're getting more and more phone calls per day, and when we do, we're pulling out one of these templates. And it's important to go ahead and get name and phone number. I think this is up front so that you can reach them later if you need to. And what we do is just go through basic questionnaires. We're trying to keep all of our templates on one page just for simplicity and efficiency, and some of them are on two. But once you get through this is basic history and physical, you can go through you can actually do a telephone assessment based upon how the patient sounds. Do they exhibit difficulty with breathing? Are they given indications of stress or pain? And is their conversation and questions and answers appropriate? And it just gives more information on the chart here of your assessment on the patient's severity of illness. And if you deem, based upon your assessment, that and you're confident that this patient has mild symptoms, or that the child that the parent is calling about has mild symptoms, you can give them instructions. And because many of these patients are going to be now struggling with their daily needs because they're isolated, and if they have family to help them get what they need, then they may not need additional assistance. But you might also, at the end of this questionnaire and the form, ask the patient or the family if they need any assistance whatsoever, and that's where your volunteer force comes into play. If they need a prescription to be picked up, that'll save a trip to the pharmacy that might potentially expose your local pharmacist and staff. And so that's a way to identify which patients and families might need some assistance if they are going to isolate. And we have another template for triage, which is for adults. Slightly different, modified as appropriate. And for a medical screening, and we're going to, and I think probably most facilities are going to make quite a bit of good use out of medical screening exams, which is part of our federal requirement under EMTALA. And these are the patients that present to the hospital that you are making a determination do not have an emergent condition, but yet at the same time very well may have coronavirus infection. So again, I'll reiterate that if you think they have coronavirus infection, chances are they're going to be mild to moderate in severity, and that they do not need to be certainly inpatient, but that a vast majority of them do not need to even step foot in your hospital. So could you evaluate this patient in their own vehicle? And this is the first question we're asking, because we are doing drive-up testing, and I'll talk a little bit about that, but we're also doing medical screening exams through the patient's car window to determine severity. So when we see a 2-year-old toddler who is brought in by a parent or a grandparent for a fever, and we're able to see that toddler in the back seat eating Cheetos and drinking juice and playing and laughing and smiling, then we know, despite the fact that this patient may very well have coronavirus, that this child does not need to be in the emergency department and exposing the staff, and that child will almost certainly do very, very well at home. And because this illness affects the young, and particularly children, much differently than the elderly. And there's very, very few cases of children who have suffered severity or mortality of illness when they are infected with coronavirus. So medical screening exam can take place, of course, in the emergency department. But if you can head these patients off before they enter your hospital and even conduct that exam, and it doesn't always have to be a hands-on exam. Again, if you see a child laughing and drinking juice in the backseat of a car, that child does not, at this point, if you think they have coronavirus, need to have a stethoscope laid on the chest or vital signs checked. They can actually be assessed fairly accurately by a visual exam and by talking with the family. So that's a medical screening exam form right there that we're using. Okay, so once the patient does have a severity of illness that we deem to be appropriate for the department, we can then pull out our assessment template and go through the full exam in template. And we're making this fairly user-friendly by making and placing check boxes. And again, we're trying to keep it limited to 1 page so that we can have a efficient throughput of patients. Anticipating that we may have surges of patients that could be upwards to 10 times the number of patients that we would typically see in the emergency department. So if you have an emergency department that might see 40 patients in a day, you may very well have up to 400 patients trying to come through your emergency department at the peak in approximately 2 months from now. And so, of course, many of those can be medically screened. Many of those can be telephone triaged, but many of them will still make it into the emergency department because of their severity of illness. And when they do, and your ability to do these templates or do these patient medical charts in the computer becomes overwhelmed, these templates may be of, I think, quite a bit of value and efficiency for you and for your departments. They could also be modified, and you could put this information into electronic form, but depending on your system, the efficiency won't be the same.
Right.
And so we have both adult, for all of our templates, we have adult and children. We have a nurse template as well, and person under investigation is a term that's used pretty regularly, sort of known as PUI, and these are patients that you believe have coronavirus, and you're putting them through that evaluation. So the nurse note and assessment is also something to be used, and this has a different type of information down at the bottom. And it's important also to keep in mind that your medical screening exams can also be done by nurses. And depending on your staffing and your availability, if your provider is overwhelmed and you have patients who are minimally ill that are presenting, your nurse can also do the EMTALA medical screening exam. And once we get to a patient that is going to require admission to the hospital, we have two sets of admission orders. We have pediatric and adult admission orders. These will probably be the least used because, again, children are, for the most part, experiencing mild symptoms, if any at all. Some of the children, and maybe even a majority of them, are infected and are transmitting the virus, but are without symptoms. So this will probably be seldom used, that we have to admit children, but for those patients who have asthma and other pulmonary disease, this may become something useful if you do have those children that need to be admitted. And then we have our adult as well. And you'll see that we've placed check boxes in front of just about everything that we could, so that we would be able to rapidly go through these orders and check them off. Antibiotics will become necessary in some of our patients who end up having super infection, pulmonary infections by bacterial origins. And this is something that we saw quite a bit after the Spanish influenza. But I think for coronavirus, we're not sure what proportion of our patients are going to have bacterial pneumonias, but we do know some of them will. But a large number of them have primary viral type pneumonitis and pneumonia infections that are becoming classically visible on X-rays and CT as a ground glass appearance to the lung tissue. ARDS is also something we're seeing in the critically ill infected. And that's page 2 of those orders. We have 2 sets of discharge orders or discharge instructions when the patient either leaves the emergency department or the hospital, one for children and one for adults. And again, those can be modified to the needs of your providers who like to put and have preferences in what they give out as instructions. And again, these templates are to be shared. Of course, the logos can be taken off, and you'll put your own logos on there, and your phone numbers, that, for instance, right here, will be changed to your phone numbers. And then anything that you would like to edit is based really upon your preferences, your provider preferences. And so these are the templates. You guys are welcome to utilize as much as you want, and we hope that they'll even be used outside of Oklahoma if other rural facilities would like to use them. So feel free to pass them out and share them by email to other facilities that you know of. And with that, I'm happy to take questions.
All right. If anyone would like to submit a question through the chat box, I'll be watching that. And then I believe most lines are muted. So if you just want to go up and click unmute on your line, feel free to do so. I know we have a handful of folks who are just called in, and I will go in right now and unmute your line. All right. Does anyone have any questions for Dr. Brandenberg? We have one in the chat. Is reporting done by location of test or location of residence?
That's a question that I believe it is probably both, but I don't know precisely how the state health department is accepting that. But I suspect that they want to know where the patient resides as well as where the test was done. So I would probably say it's both. When you see it in the news, I think that's where they reside.
Any other questions?
I have a question. Are we supposed to be reporting presumptive cases to the state or just positives?
At this point, just test positives. But with that in mind, I would say all upper respiratory patients that you are concerned about that we don't have available testing, I would assume they're coronavirus positive and ask them to isolate for 14 days. and that includes their families members as well in the home.
Thank you.
Mm-hmm.
Well, while people are thinking of questions, I just want to take a moment to thank you for sharing all of your tools, templates, and just your great expertise with us. This has been a very informational and great webinar.
You're most welcome, and happy to do this again if there's an update that's needed, or as we go into this, if there's more information that needs to be shared, I'll be happy to help you out.
Well, we really appreciate that. We did have a question. How do we get a copy of these forms? They were attached to the email invitation, but also we will have them posted on our website along with the link for this recording, and I will get that out shortly. Any other questions while we have Dr. Brandenberg on the line? Well, as we move forward, if anyone has any questions, please let me know. And like Dr. Brandenberg mentioned, as we get a couple weeks further or a few weeks further, if it's worth everyone's time to get back on a call and have further discussion of what are you seeing, what are you doing, or what things are looking like, we can definitely set that up. Thank you all for your time, and most importantly, thank you, Dr. Brandenberg. But yes, we will. Please keep us in the loop. We want to help, and be safe, and everyone have a great day.